and your attendance is consent to be recorded. So thank you for that. Today's presentations will be made available, and as well as the recording of today's session on the HHS ASPR Outpatient Therapeutics website, and we'll share a link to that in the chat. And you should have that on the announcement that you received today and in the future. We will be offering CME and continuing professional development credits through the University of New Mexico, where Project ECHO is based. We will share a link to the survey about 15 minutes before the end of the session. The link should also be in the announcement that you received today about this program. And you will have 48 hours to complete the CME survey to get the instant CE or CME. We really value your input, so please take advantage of that opportunity. Just a reminder that these learning sessions are focused on improving patient care and health systems and supporting clinicians. Please, let's keep them apolitical and non-commercial. Thank you for that. And just a word about data use. You share data with us when you register, when you put questions in the chat. We want to just ensure everyone, we take data stewardship very seriously and keep your data confidential. Most of it is de-identified up front, but any data we share with HHS ASPR is all de-identified. And just briefly to go over the agenda for today's session, which is focused on equity in underserved populations. This is the 9th session in this mini-series. And we have 2 case presentations. The first will be on improving equity and access to COVID-19 monoclonal antibody treatments. We'll be hearing from Marta Wojcinska. And then we'll have another case presentation, increasing the use of monoclonal antibodies in minority communities. And Gary Pukran will be leading that off. We'll have a brief Q&A with each of those following them, and then we'll shift to a longer Q&A session with our group of distinguished panelists. So with that, it's my pleasure to introduce Dr. Marta Wojcinska, who is the Deputy Director of the Duke Margolis Center for Health Policy in Washington, D.C. So Marta, the floor is yours. Welcome.
Thank you so much. And thank you so much for inviting me to speak at Project ECHO. It's been an incredible series, and we've actually been following it closely. So in this series, you have largely been hearing from providers, but I am a health policy researcher. And since last September, we have been doing a lot of work on monoclonal antibodies, both looking at what is the existing evidence base and how we could go about developing more evidence, looking at some of the payment considerations for infusion, as well as a lot of work on creating access to these treatments. What we have also in the process talked to a number of clinicians, a number of stakeholders that have been trying to improve the access to these drugs. If we could switch to the next slide, please. What I'm hoping to do is to provide you with a perspective. I don't necessarily have numbers to tell you to what extent the racial and ethnic minorities and some other underserved communities are experiencing problems with access, but I would like to lay out some of the dynamics and to describe why there is a paradox with a product sitting unused, despite the fact that a number of people eligible for this treatment far exceeds actually the number of available doses. I would like to talk a little bit about where progress has been made, why the progress has been unequal, specifically identifying areas where it has been unequal, and describe some opportunities for improving equity in access when it comes to these products. So if we go to the next slide, please. So this graphic is the number of cases that have been reported since November 9th, when bamlanivimab was issued an emergency use authorization. And these numbers are through about last week, as well as the number of courses of monoclonal antibodies both from Eli Lilly and Regeneron drugs that have been allocated since that time. And what you can see on the left-hand side, we're talking about 17.5 million people were actually diagnosed with COVID-19, of whom it's challenging to say exactly how many are high risk, but just looking at what share of the population is over 65 and what share of the population has BMI over 35. And you can see that perhaps more than half of people who have gotten diagnosed are considered high risk. And so you see this potentially really large mismatch between the number of products, but then we also are hearing that the product is sitting unused on the bookshelf, on the shelves in pharmacies. So if we could go to the next slide, please. And really what is going on is that the care pathway is quite complex. There are many steps in the process, often with a different player. So you might go to CVS or to a county testing site. You have your provider is not going to be affiliated. You might have a independent healthcare provider or a community clinic that you go to. And then an infusion site might be at the local hospital. And it's not only that there are many steps, but timing really matters. So the drug works best if it's used early. And you really only have 10 days. And I'm realizing that in the slide, it says 10 days since infected. It's really 10 days since the patient has started to have symptoms. So it's a little bit more time. But still the time is relatively short. And this entire pandemic, we have been told, if you get sick, stay at home. You should get tested, but stay at home, isolate, rest, and drink liquids. Don't come to see the doctor and you're really unwell. And so what you see here is that you see tremendous drop off at each step. Not everybody is going to get tested or get tested in time. It takes time to potentially receive the results for PCR tests, and you might end up timing out by that time. Not everybody then might go to the doctor. Not everybody might get scheduled. And then there's also drop off with infusion. So what has been happening is there's been a great effort to basically take every one of these blue lines and shift it as much to the left so that there is much less drop off between the steps. But if we can go to the next slide, please. There are really strong access inequities that exist in the care pathway. So the picture that you just saw does not look the same across communities. And this is perhaps not surprising. It's been the case throughout this pandemic. And it's the same communities that have been hard hit by COVID also face a much more challenging care pathway for COVID-19 antibody treatments. So if you look at this pathway, and if you are in an integrated health system, you might get tested within the system, and then your prescriber is right there, and they might be able to infuse you. And so the opportunities from streamlining the process are tremendous. But for a lot of the communities that have been really hard hit by COVID, the drop-off is tremendous. So for one, we tell people to test, but testing positive might actually have economic consequences. And so some either for you or for those you live with, so you might not want to test. And you might end up testing when things get really bad and you end up in the emergency room. At that point, it's very likely that it's actually too late, and because this drug is only indicated for patients who do not need oxygen or need to be hospitalized. And these patients are much more likely to be in a situation where the testing site is separate from their prescribing doctor, if they even have one, and if the infusion, and there might not be an associated infusion site. That means more time, more disconnects, and also transportation may be a problem. So even if patients get scheduled for an infusion, at this point they're known to be COVID positive, and they might have to take the bus to come back, and that might be another reason why they might not be able to complete the process. If we could go to the next slide, please. In terms of what opportunities exist, I would put them in 3 areas. One is thinking about allocation and where the product is allocated. Another one is streamlining the care pathway. And there are lessons to be learned actually from integrated health systems and others who have tried to find ways to streamline the care pathway. And the last one is proactive outreach to high-risk individuals, trying to, if you could go back really briefly to the slide before, is to really consider the drop-off that you see between the orange, the infected, and where the true care pathway starts, which is the testing. So that's what I see as a really important step, and I'll talk about this briefly in a moment. We could skip, I guess, now 2 slides and the next one. Thank you. So let's talk a little bit about allocation. Allocation followed what I call the remdesivir model from last year. So the United States government allocated to states, and then states were going to allocate it to administration sites. And those administration sites initially were specifically hospitals, but then it was opened up to many more. The problem is that states followed the remdesivir model too faithfully, and they continued to really allocate it largely to sites that are associated with health systems without really opening it up. There are some exceptions, and this is, making adjustments to this model has the possibility of affecting equitable access to the product. So I want to give you some examples of where this has worked. If you could go to the next slide. There are some states that have actually set up their own infusion centers. For example, Maryland set up a number of infusion sites, and they're strategically positioned across the state to bring them closer to the communities that might need it most. And this was very much done with equity in mind. And there are other states that have done it. Even without the infusion centers, some states, for example, have deployed another community that has been really cut out with the traditional remdesivir model is the long-term care community. These patients have a really hard time getting to testing sites. And so some states, for example, have been deploying what they call MAB squads to go to nursing homes and administer the drug there. If we could go to the next slide, please. So because a lot of states are following the remdesivir model and sending it really to hospitals, ASPR created an alternative allocation path. If you could go to the next slide, which is the SPEED program that does create a pathway for long-term care facilities and especially for FQHCs to order the product directly. We could go to the next slide. So in terms of best practices, again, this is where bridging testing to infusion is really helpful. Using rapid tests, if the community center has EHR records to identify high-risk patients and be able to identify them and then bridge it to all the way to infusion. So you have heard in this series from some FQHCs that have actually been able to take it all the way and infuse. But if that's not possible, if you could go to the next slide, streamlining goes beyond just internal processes and making sure that the handoffs internally are done well. It also might mean providing information about what the next step is. So knowing where to, if you can only provide the drug, test for it and provide the drug, know where you could send the patient, know what the next step is. And there are a number of locators. This is a screenshot from NICA, the National Infusion Centers Association, that provides information about where these products can be administered. And potentially partnerships. I know in this Project ECHO, there was a discussion from Nebraska Medical where they partnered with an FQHC, and specifically that particular FQHC could send their patients to Nebraska Medicine. If you could go to the next slide, please. And so I wanted to come back again to the proactive outreach. I believe that for the racial and ethnic minorities and for the underserved populations, this is a really big stumbling block, is that patients don't get tested or don't get tested early enough. And this is before providers really come into place. And so I see this really as a great opportunity to engage with community organizations and try to educate them about the fact that this treatment does exist, and that this treatment requires that you get tested early, and that you seek to speak with a provider who would be able to prescribe this drug for you. And very last slide to wrap it up. So just wanted to say that we have just issued a paper that looks at some of the promising practices for promoting utilization of these treatments. And I recommend you go on our website to have a look at it. And we have another one that's forthcoming in the next few days, I believe, on best practices by states. So I'll end with that. Thank you so much.
Marta, thank you. I really like the way you used the care pathways to frame your overview. It was very clear, and to highlight the equity issues along that pathway. So the first question I have for you is, what additional efforts can policymakers across different organizations put in place to help bridge the equity gap and improve access to treatment options during the pandemic?
So I give ASPR a tremendous amount of credit for creating this new pathway. This is really important. The place I think that where I see an opportunity, and this is where states can play a role, community organizations can play a role, is to be doing this proactive outreach. That's where I see, I think, the biggest opportunity. And I'm really excited that actually Haim is on this panel, and we'll be able to talk about some of their efforts a little bit later. But I do see that as the biggest opportunity for these kinds of partnerships. And you know, states and the federal government do play a role there.
So my second question was, and we will get to Haim in a bit and look forward to the example he will share, but can you offer any other specific strategies about targeted outreach efforts that might be useful to the audience?
So I would group them into two buckets. One is really community-based, where you engage with churches or organizations that have a great footprint. And the other one is really through public media. If you look what has been happening in Texas, and Jaime will speak a little bit more to their efforts, you will also see that actually the governor has been very outspoken about about availability of these products and getting the word out. If you, especially when the state has been involved, there's been a lot of stories about availability of this product in the media. So engaging the media can be really helpful. And it could either come through the government, it could come through providers, through health systems, it could come through community organizations. And I think this is the next important frontier, I think.
Great, thank you, Marta. We're going to transition now, and I'm going to pass the baton to my colleague, Dr. Christian Reimers. Christian is an infectious disease physician who is also the chief of population health at Family Health Centers of San Diego, which is a large federally qualified health center network. Christian, over to you.
Thank you, Bruce, and thank you, Marta, for setting the stage for us. We're going to move to our polling question that we usually do, just to check the pulse of our participants here. So Amanda, if we could bring up the polling question. Same question as usual. Has your healthcare facility or system infused any patients with COVID-19 monoclonals? And you have several choices: yes, no, no, but planning to, don't know, or not applicable. And we'll give you about 5 more seconds before I introduce Gary, our next speaker. I want to get at least 50% response, and we're already there. Okay, 3 seconds. All right, good. So the majority are already infusing now. We have about 10% that are planning to. Okay, thanks for that. We can take the poll down. I think you can click the X on the top to get rid of that window. So great. Our next speaker, we're very privileged to have Gary Puckren, who's the president and CEO of the National Minority Quality Forum in Washington, D.C., which he founded in 1988. The Forum is a research and educational organization dedicated to ensuring that high-risk racial and ethnic populations and communities receive optimal health care. And Gary founded that after a career as a history professor at Rutgers, I understand. So Gary, it's great to have you with us, and the floor is yours.
Well, thank you so much. Appreciate the opportunity. So the National Minority Quality Forum, we have been working in COVID since June. We have been running a study with FQHCs in 5 states in which we have been doing PCR tests and serology tests. So we've had a pretty good feel for what's happening at the community level. And one of the things I would quickly observe is that from late June through about late August, the PCR test, the turnaround time was about 15 to 21 days. And so when you start to talk about monoclonal antibodies and using them, the problem was that our system was really not geared to get information back to patients quick enough so that they could really take advantage of the monoclonal antibodies. Things have calmed down dramatically. I think turnaround time now is somewhere between 2 and 3 days, and so the opportunity is there. Since then, we have been working with another 12 community health centers around the country, doing a program that educate about the vaccine, as well as we've been talking to them about the monoclonal antibodies. And universally, when we're talking to the chief medical officers, there's some awareness of the monoclonal antibodies, but they're not using them. And certainly in the community around which they serve, and these are minority communities, African American, Asian, Native American, Hispanic, rural communities in some instances, rural Georgia, rural Mississippi, rural South Carolina. The community doesn't know anything about the monoclonal antibodies. And so we started to educate about the monoclonal antibodies. And what we realized is that, particularly with the vaccines, the way the vaccines are being distributed, minority populations, at least the majority of them, are not eligible for the vaccines right now. We can talk about why that is, but they're really not eligible. So it's really important that we use these monoclonal antibodies because of the high rate of hospitalizations, mortality, and even infection in minority communities. And one of the ways to reduce the risk that these patients are suffering is through the monoclonal antibodies. So we've decided to put together an initiative to really work with the 17 community health centers that we are working with as a way to maybe launch a national conversation about using the monoclonal antibodies. And we thought the community health centers were really perfectly centered to do this work. 2 critical things that they're doing. Number one, they are doing the PCR test, and they are calling up the patient, particularly those who are positive, and telling them they're positive. And we thought that that's a great moment where they could go through the protocol and see who's eligible for the monoclonal antibodies. And so we're starting to work with them to, one, do some quality improvement so that their staff gets trained when they're making those calls to make the referrals where appropriate for the monoclonal antibodies. The other thing that we're doing, and it's really interesting, what sticks in my mind is back in August, the projections were that we were going to have 500,000 people were going to die from the virus by the end of February. And here we are at the end of February, and 500,000 people have died. What I was struck by is that we did take those projections down to small geographies so that in community, people would have a sense of the risk and use that to have conversations about wearing the mask, social distance, vaccines, monoclonal antibodies, et cetera. So what we decided to do back in July was to begin to do some forecasting of viral surges at the zip code level. And we created something that we call the COVID Index that we are partnering with these 17 community health centers. And what we're doing is we're giving them some estimate of the number of new cases, the number of deaths that they can anticipate in their community over the next 30 days. And it's a continuous weekly updates that we provide them. And we think that begins to empower them again, for the vaccine conversation, for the conversation about continuing to wear masks, but it also empowers them to have this conversation about using the monoclonal antibodies. We don't find a lot of resistance to the monoclonals. What we find is that people just don't know about them. The other challenge is we don't know where those monoclonal infusion centers are. So one of the things that we have been working on with the National Association of Infusion Centers is to see where the monoclonals are, the infusion centers, I'm sorry, are in relationship to minority communities, specifically to the community health centers that we're working with. Obviously, you don't want to start asking people to prescribe monoclonal antibodies in communities where they're not available. So we're undertaking that work right now. Quite honestly, in some of the interviews that we've done in rural communities in Mississippi and Alabama and South Carolina, we suspect that those the infusion centers are not close. And so I was very intrigued. I heard someone earlier in the lead up to this talk about using infusion centers in cars, and that really piqued my curiosity because we are going to have to figure out how to create pop-up centers or something. And if a car will do, that sounds like a great idea to me. So I already took away something from this call. At the end of the day, the challenge is we're seeing disproportionate outcomes in minority communities. These do not have to happen, right? My sense is that we in the healthcare system, and I sort of, even though my degrees in history, sort of see myself as part of the healthcare system, we have a responsibility to our communities to make sure that we're reducing risk. It's always about reducing patient risk. And to sit around and talk about 500,000 people die and not feeling guilty about that, or having minority communities with disproportionate outcomes so that they've lost 3 years of life expectancy in the 21st century, 3 years of life expectancy. We all own that, really, quite honestly. And so what we're trying to do is to see what we can do about putting a plan into place. I would recommend to those who are listening, who have community health centers in their community, they make a great partner for you. They have trusted voice in the community. They know the community. They're doing PCR tests. They're doing the vaccines. They can do the monoclonals if you work with them. So if you really want to make a difference, I think that's a place to go. I think it's a little harder in private practice because the patients may get the test and the physicians may not know they got the test and when they got the test and how quickly to make the recommendations to them. And so I think the community health centers offer that opportunity. And more importantly, they can start to get the message out in community because word of mouth as we start to work can also make a tremendous difference in these communities. So starting March 15th, we hope to have the full program launched. And we're excited to be engaged and happy to partner with anyone. And certainly we're happy to share some of the predictive analytics that we work on. I won't shine them up and say that they're the Nobel science here, but they're better than anything else that we got right now. And so if it's helpful to you, we'll certainly make those available. Thanks.
Thanks a lot, Gary. And I think as a history professor, you are exactly the right person to talk to this issue. I saw something on NPR talking about equity and polio vaccine in the 50s, and it seems like we're replaying kind of the same issues that have happened before. You know, I work at an FQHC, and one of the major issues that we have in our populations of color is trust. And I'm interested in your perspective on whether a lot of the hesitancy comes from trust, and then how outreach plays into that. Should the outreach be done by the actual FQHC itself or by another entity, by the state? What's your perspective on that?
My experience with the FQHCs that we've worked with, they have deep trust in the community. The example I would give, so we launched this 5-year study looking at COVID in minority and rural communities with FQHCs. We were recruiting 1,000 participants in the study. They were doing that in 60 days. I mean, who recruits 1,000 people into a clinical study in 60 days? And the only way you can do that is because people trust you. That people, when you call them up and say, I'd like you to participate in a clinical trial, they'll do it. And that's my experience with community health centers, is that they're deeply involved in the community and people trust them. And we need to build on that. We need to take advantage of it.
Another issue is that sometimes the public isn't ready to hear efficacy data, or they're not interested in efficacy data. They want to hear stories and positive stories. Have you been involved in getting positive stories in minority communities out there to increase the awareness?
You know, so the answer that when we talk about the monoclonals, what we say is there's very little evidence that they do any harm. And there's evidence that they do some good. So the risk proposition is, do you allow the patient to take the risk of ending up in the hospital or dying when you can give them a therapy that won't do them any harm and has a tremendous upside to do them some good? And I think that's the way we talk to people. We talk to them about, our job is to reduce your risk. We're not going to give you anything that elevates your risk. We are constantly looking at it. Obviously, the science changes, and when the science changes, we have to adapt. But right now, these monoclonal antibodies, particularly in minority communities, where the eligibility for the virus, for the vaccine, is not there yet for the majority of them. We have to use these monoclonal antibodies to keep them out of the hospital and reduce those mortality rates.
Great. And the last question for you actually comes from our Q&A feature from Rick Foster, who says the biggest barrier for getting more FQHCs in community clinics involved in monoclonals is not the product, not the cost, but it's rather limitations of space and staff. Have you seen this in the FQHCs that you're working with?
Oh, absolutely. You know, just to be blunt about it, FQHCs are not going to be infusion centers, right? Because of two things. One, obviously the size of the facility, but also because you're bringing COVID people into the health center, which is going to bring risk. And that's why, if we could put them in a parking lot, in a car, and infuse them, great idea, I love it. If we have to set up a tent, let's do that. Get a mobile van, whatever you got to do. You know, this is not rocket science, right? We can figure out ways to give people infused without having to put other people at risk. And so I think there are opportunities there, but absolutely right. Just going to an FQHC and saying, I want to turn you into an infusion center, not going to happen.
Thank you, Gary. So it can happen. It's difficult, but I think we'll hear some examples of some really creative solutions in our panel. And I'm really curious to hear about the mobile-based infusion out of the car. But thanks for your time and your perspective. So we're going to have Marta and Gary will stay on the panel, and I'm pleased to introduce the rest of our panel. And I think what I'll do is give you each a minute just to sort of tell us who you are and where you're from and what you've been doing. Let me introduce you all first. So Nicole Lamoureux is president and CEO of the National Association of Free and Charitable Clinics in Alexandria, Virginia. And she works with 1,400 free and charitable clinics and pharmacies to ensure the medically underserved have access to affordable quality healthcare. Amy McEntee is the Chief Medical Officer of Salud para la Gente in Watsonville in Northern California. She's a family medicine physician with an interest in migrant farm worker healthcare and community health. We have Sabrina Edgington, who's the Director of Learning and Curriculum Design for the Association of Clinicians for the Underserved, based out of Nashville, Tennessee. And Sabrina works across her organization to identify issues and trends in delivering care to underserved populations. And finally, we have Chaim Leibovitz, who's the co-founder of the COVID Plasma Initiative in New York, which is an initiative that's been focusing on plasma as well as antibodies and early treatment of COVID, with the main goal of educating patients on potential treatment options that are available and navigating and linking patients. So let me go in that order and just give you an opportunity to tell us what you do and your perspective on equity, and we'll start with Nicole.
Thank you so much for having me and including me in this conversation. The National Association of Free and Charitable Clinics does represent 1,400 clinics. We are not federally qualified health centers. We are the net below the safety net here in this country. So we serve 100 to 300 below poverty, our patients. 83% of our patients come from a working household. And what COVID has taught us is a few things. One, first, as providers, we need to stop and listen. We need to hear from communities to tell us what they need, not necessarily always what we think we need. For example, we have understood that some of the documentation on COVID antibodies comes out at a 12th grade reading level, and we need to take that to a 4th grade reading level for our patient perspective. When we think about language, we think about Chinese, Spanish, Portuguese, but we also now need to be looking at African-American vernacular English, Pidgin, Cajun, and other ways that we can speak to people. So translating information into languages everyone can understand, not just languages, frankly, that white people think we need to understand. We also have providers who look like our patients. As we heard about our FQHC partners, we pick up the phone and we call our patients and we talk to them. I broke both of my ankles 2 years ago, and I jokingly say that if I went to a free clinic or an FQHC, they would have asked me how to get to work. Am I okay getting to work? I went to the ER and they said, here's 2 crutches, swing. And I think there's 2 very big differences on how we care for our patients. I also think that we're finding new ways to get care to a community. For example, if you have a mass infusion center that's not on a bus line, or that's not easy for people to get to, they're not going to come. So making sure we have places like we've done, which have been walk-up testing sites, vaccination sites, as well as drive-through, as you're going to hear later from other people, finding ways to speak to the community in the language that they want to hear and they need to understand is something that I'd say free and charitable clinics are a great partner for. And also we're the community's voice. Sadly, we're America's best kept healthcare secret, but we're the loudest secret you have ever heard. So when there are places for community forums or places to get people to talk about antibodies or other places, we're going to be there, not just on TV, but going into the community centers and talking to people because they trust what we do. And we're really just happy to be here to have this conversation.
Thank you so much, Nicole. Over to Amy, who has done some unique work with popping up clinics in the mobile setting in Watsonville.
I am at Salud para la Gente. We're a federally qualified healthcare center in Watsonville and serving primarily farm workers in our community as well as other essential workers. And the community's been very impacted by COVID. At the height of the surge, our positivity rate was 45%. Our response to COVID throughout this pandemic has really been based in community partnerships. We've had strong community partnerships with the local university, the public health department, and all the other nonprofits, and that's really been key to our response. We started testing through UC Santa Cruz in July, which has allowed us to have plenty of resources to test and get results within 24 hours or less. And we've also, earlier in one of the presentations, there was discussion about concerns about losing wages if you got tested and you were positive. Through our community outreach department, we have had a partnership where there's been donations. So people who don't qualify for some of the wage replacement programs have been able to get wage replacement when they're tested through us and referred through that program. And then through public health, we've contracted with them to do the contact tracing and investigation. And then most recently, we've started the monoclonal antibodies, which we thought was really important when we saw so many of our patients being impacted by COVID, and knowing that there was a treatment that was available, we thought it was important to include that. And we have done it outdoors in a drive-up fashion.
Christian, can you unmute?
Happens to the best of us, huh? Sabrina, over to you. Can you detail what your organization has done to address these issues?
Sure, I'll be really brief just because I'm looking at time. But we were actually founded by members and alumni of the National Health Service Corps. We have a cooperative agreement with the Health Resources and Services Administration. We're really looking at strengthening the health center workforce. And part of that is trying to bring in more diversity into the health center workforce and make sure that the health centers look like the communities they serve, represent and reflect the cultures of the communities that they serve, and build that trust and engagement so that we can have more equitable care across different communities.
Thank you, Sabrina. And finally, Chaim, if you could outline your work to do with non-English speakers.
Sure. So I'll give you a little background. I'm actually a small business owner. I own a shoe import and wholesale company, and we co-founded the COVID Plasma Initiative, meeting through a reporter from the Wall Street Journal who wrote an article about some of the activities we were doing, and that's how we met. We started with the plasma collection back in March of 2019, and we kept on expanding to other therapeutics and trials that are going on. One of the things we found early on was that the only way to really get the message out quickly, and time has been against us since the pandemic started, was working on a very hyper local level with communities. That was true with plasma, that was true with any of the therapeutics that are out there. I'll fast forward to the monoclonals. What we found with monoclonals was there were a lot of misconceptions. People thought they have to pay for it. People thought that if they don't have coverage, they can't get it. Institutions thought that it's a scarce commodity and they're not going to get more than 10 or 15 doses, and they weren't willing to put in the investments to set up infusion sites for it. What we found was, as a group of, it's probably about 30 volunteers, mostly small business owners, we tried in every situation to see what can we do with the existing resources to get it available to everyone, especially the ones that will not be able to get it done themselves. So for an example, in Baltimore, what we did, we set up in an ambulance garage where they have like a big training room. What we did, we set up an infusion site over there. Baltimore has their infusion in the convention center. It's probably two of the better hospitals in the country, Johns Hopkins and University of Maryland. But the issue was it took 5 days to get an appointment for when the person called. That excluded most people calling because people called when they were 5 or 6 days in. So we were able to get it done in a way where an average of 12 hours after a patient is referred to, they get the infusion. So what we tried to do is to get the existing resources, get it to the patient as fast as possible. One of the people that, one of the associations that I work with is the Fight Is In Us. That's mostly the blood bankers, the Gates Foundation, a lot of different community leaders on there. And on one of the conversations, I heard how badly some of the people in the Hispanic community were doing in Texas. So I reached out to Joe Lopez, who's one of the people on that coalition. And I told him, I said, Joe, there's no reason why you can't do everything we're doing, in the New York area. So we were able to reach out to the people within the community, that they should have the knowledge of what's available. Talk to the different infusion sites to figure out what would be the best way for them to set up their infusion site where they'll get the most infusions done and in a timely manner. And we were able to get, for instance, the city of El Paso's infusion, the Civic Center, from like 100 infusions a week to over 1,000 within a 2-week turnaround time. And that's something we can do, in my opinion, at least, in any community across the country. There's no reason why we shouldn't.
Great, thank you so much, Chaim. We're going to move into the general questions, and thanks to all of you that have put them in the Q&A, and thanks to the panelists who have been able to multitask and answer those questions. Keep them coming. The first one I'm going to direct to Nicole. It's a question about insurance from Rebecca Delazio Basley about whether these treatments are covered by Medicare and Medicaid, and what do you do with an uninsured patient that qualifies?
Sure. So for the uninsured patients, and then I'll kick it over to my FQHC counterparts to address the Medicaid and Medicare kind of questions out of this. But for uninsured patients, as we look at these monocles, and we work with our infusion sites and our partners, things are covered. As the administration side of things you can bill for, but we don't bill, so we don't have that. So we have access to those. And I will be honest, we're very lucky with uninsured patients in most of our facilities that we work for. Anything that's not covered, we're able to get donations. insurance to cover some of those costs for our patients, such as getting a patient to and from the infusion site. So making sure that it's not just the infusion we have to think about when we think about these. How are we going to get them back and forth? Is that helping with Uber or some sort of transportation to get them back and forth? We're lucky enough to have people to donate those. I would have to kick it over to somebody else to address the Medicaid conversation since we're outside of the Medicaid billing area.
Amy, do you want to comment?
Yeah, it is covered by Medicaid for us, and at least in our managed Medi-Cal program. For patients, we do have a fair number of uninsured patients, and we do work to get them enrolled in a program for insurance when they come in. But if they're not, as an FQHC, we're required to treat everybody regardless of their ability to pay, and we will treat them.
Great. So there's a lot of discussion about where the infusions occur. There's a couple of creative solutions to this. One is through partnerships. One is through doing it yourself. Marta, if I could get you to comment on the concept of just a pop-up clinic, kind of putting one up where there wasn't one before.
Yeah, so I just wanted to add that a good model from the Red Cross, aside from potentially using the vans, is to really do what they do most, and that's to engage with the community. And so they will set it up in a school, and a lot of schools are closed right now. They will at a school gym, they will do it in a church basement. So there are opportunities to either partner with community organizations or perhaps with the local governments and find a site that's likely not being used right now that will allow you to keep the COVID positive patients from the patient population that you serve. What you still have to do at that point is to identify staff who could staff it. But I think the constraints around space can be worked around. And I think the Red Cross is a good model for that.
Thank you for that. Sabrina, a question over to you about hesitancy. We've heard of hesitancy from the patients themselves, but we've also in this forum over the last 9-10 weeks heard about hesitancy from providers. So can you comment on efforts to sort of increase awareness amongst providers?
I think amongst, the more education that we can provide that's not going to take, that's not in a 100-page booklet, the more that you're going to have people buy into it. I think it's just, there's a lot of myths, there's a lot of trust issues going around that need to be addressed when it comes to provider hesitancy. But I think also, what's really important that we need to talk about, just going back to working with communities, is the trust there, because we're facing more trust issues in our communities that I don't think we're necessarily addressing in the right way. And I want to bring up an example of where I was in a town hall, as a social work town hall. A social worker who is based out of Harlan was approached by an academic institution and said, hey, we want to address vaccine hesitancy in your community, and we want to do that using psychoeducation. Her response was essentially, how dare you? And so I think, that's hard for people. What should have happened and what the conversation should have looked like was, one, first, recognizing the history of abuse and racism in healthcare. Two, apologizing because you are the healthcare system and you're part of a system that has perpetuated that. Three, talking about the options that you have available. And then four, working with the community leaders and the community organizations on outreach and education opportunities. So I think too often we come in with, this is our grand idea, and we lean too heavily on our evidence-based and academic training and forget to really co-plan these strategies and work collaboratively with the communities we're in.
Thank you, Sabrina. That was very well said. It looks like Chaim has a comment, and then I want to go to Amy and Gary for our next question.
One of the things that we found, and that was across all the communities. So for some reason on the monoclonals, the clinicians or the physicians are a little bit behind, and you can understand why, because the ones that are in the hospitals, they almost don't see anyone that took monoclonals, and that's a good thing. That means that it's actually working. And most primary care physicians are not familiar with it. What we found was, we did more education directly to the patient, And once a physician heard from several of his patients that got it and got it early and had very good results, that's when they started referring patients to it. So that's why we found, of course, this is different states, different communities. We really have to reach out to the patients first. And the way we presented it, and I have the benefit of not coming from the healthcare system. Up until a couple of months ago, you had nothing. The healthcare system had nothing to offer for us, for someone who wasn't very sick. Now they do have. Let's use it.
Thank you, Chaim. So a question from the Q&A, and I'll direct this at Gary and Amy. From Zeldi Oppen, does anyone know about expanding access beyond the EUA criteria? So if we have so much of this monoclonal available, and yet the EUA restricts it to very specific over age 65, diabetes, obesity, those things, is there any thought about expanding to a little bit more of a larger pool outside the FDA guidelines? Have you heard about that? Amy, first over to you.
No, I haven't heard about that. We've stuck with just the EAU guidelines.
Okay. And Gary? You're on mute, Gary.
Sorry about that. There are some clinical studies that are underway that are looking at expanded use of the monoclonal antibodies, but they're not approved. And so right now we are, operating inside the framework of the EUAs, but that's a pretty broad framework. Is anyone over the age of 65? Folks with asthma, diabetes, COPD, cancer, immune. So it is a very large population that can benefit from these monoclonal antibodies, and God forbid whatever happens with these variants, the monoclonals may even play an important role there. So I think we have a lot of work right now just getting to the folks who actually qualify before we start to expand.
Good. I'll offer my own clinical opinion here, which is that, with a BMI of 34.5, I think somebody probably benefits just like they had a BMI of 35, even though that is technically off-label. But, we need to be giving more of these treatments. There's a question for you specifically, Amy, from Rick Foster about handling the 1 hour post-infusion monitoring period in the drive-up sites.
In our drive-up site, it's the same area that we've been using for our outdoor respiratory clinic. So we have kind of a really large canopy where we're able to fit a couple of cars under it. So they stay there for the hour afterwards, and we continue to check vital signs while they're there. So it hasn't been an issue for us.
Great. Thanks. Marta, it looked like you had a comment.
Yes, so where I could comment perhaps, and I don't know that I can speak to whether it should be used outside of the EUA, but there are studies that show prophylaxis effects for patients that live in the same household. And so you can imagine a lot of the patients that come into an emergency room that are really sick are not going to be qualified, but you could be asking those patients, is somebody in your household at high risk? And even if before they are symptomatic, consider them for treatment. So in those specific settings, it might be beneficial. But again, this is not an approved use under the EUA.
And I'll go to you in a second, Gary, but I can just support that. And this is what COVID looks like, is multiple household members being affected. And we've often had husband and wife, grandma, grandpa side by side getting infused. That's just kind of par for the course.
And then what's helpful here is that if they come into the emergency room, some emergency rooms will provide the treatment. And so they clearly are not far along. They might not even be symptomatic. So the setting is right.
Gary, over to you.
Yeah, I just wanted to reinforce too that physicians are always have the latitude to prescribe. So, they can use good judgment as to how they want to use the monoclonals.
Great. A couple quick ones I'm going to take myself from the Q&A. What is considered early? So the EUA specifically says 10 days from symptom onset, but I think all of us using this think the earlier the better. Many of the new studies underway are actually tightening that to 5 days after symptom onset, which speaks to why it's so important for people to be aware to test early, and so important to have rapid testing turnaround times and good articulation between the testers and those doing the monoclonals. A question from Karen Leong about once you receive monoclonals, do you still need to get the vaccine? What we know currently is that the monoclonals sort of fade after 2 to 3 months. And we do still think that the vaccine can give benefit to people that have already had COVID. My practice is to wait till 90 days and then give a vaccine dose. There's discussion right now about whether people need full 2 doses of the vaccine, but certainly they should get the vaccine for more long-term benefit. I think we're almost out of time, but I did want to ask about data a little bit, because I think data would really help not only see where we are with the equity and inequity, but also maybe to move policy. So I'll start with Marta and welcome anybody else to weigh in. What are your thoughts about making it a requirement to collect and report race, ethnicity, and socioeconomic data to those that are giving monoclonals?
That would be great, but as long as it does not create more obstacles for people to get access, right? So there's always a downside to reporting, but I think such information could really help us to get a better sense of how much inequity there is in the system and where.
Anybody else want to comment? Sabrina?
I just want to say that I think it's important that we collect that data. It's very critical in understanding where the disparities are, but I also think that data needs to be shared with underserved communities so that they can be using it in their own advocacy and awareness efforts.
Great. All right, I think we're almost at the end of the hour, so unfortunately we have to close. Thank you so much, Sabrina, Amy, Marta, Nicole, Gary, and Chaim, for your insights. Really rich discussion. This is one of those issues where there's just a lot more work to do. So I thank you for your hard work on this, and thank you for the discussion. I'm going to throw it back to Tiffany to close us out.
Yeah, thanks very much, Christian. And I just echo what you just said with regard to the gratitude to our presenters and panelists and sharing your insights with us today, not to mention the work that you are doing in this response as well. Just briefly, seeing we're coming up on time, I'd just like to note that we do have another session planned on March 10th, where we'll be highlighting promising practices, lessons learned, and other insights from urgent care centers who are engaged in administering the monoclonals. So I just encourage everyone to stay tuned as we are pulling together the agenda for that session, and updates will be forthcoming. So with that, I'll turn things back to Bruce.
Great, thank you, Tiffany, and all the panelists. Wonderful discussion. Really appreciate you sharing the wisdom you've accumulated and experience. And please keep joining us in the future. As Tiffany said, next session will be the week after next. And thanks to all the participants. There were almost 300 participants from across the US and beyond. And to all those participants, thanks again. And please take time to take advantage of the CME or CE and give us your feedback and let us know where you would like to see this series go in the future. Thanks, Christian. Everyone take care and see you in 2 weeks, we hope.
Thank you.
Thank you.